So now we are going to move on to the next topic on our breakfast at UMHealth session. And it's a pleasure to introduce you to the next speaker, which is Dr. Rubendra Kumar Kalimutu from the Obstetric and Gynecology Department. He is one of the obstetrician and gynecologists in the department, and he has been under UMMC and has become a specialist for the past 2 years in our department. So she is going to speak on the impact of obesity on women health, and I think we will have the Q&A question at the end, and please write your question in the Q&A box, and I will have to read it on for me to forward it to Dr. Ruben to answer the question. So Ruben, the floor is yours.
Yeah, very good morning. Let me share my slide. Okay, so as you can see, the topic of my presentation today is the impact of obesity on women's health. So when I was given the task to present on this platform, I asked myself, and at that point, the answer was quite simple. This is the outline of my talk today. I'll speak about on overview, and then effects of obesity. I'll start off a little bit on adolescents also, then I'll go on to adults. I'll be touching all those topics mentioned, and at the end, ways to overcome obesity. So, obesity is basically a condition characterized by excess body weight, excess body fat, which resulted in excessive weight that presents a risk to health. Studies have shown that overweight and obesity increase the risk of chronic health conditions and reduce quality of life. According to WHO, obesity has been a global health concern since 1975. Well, issue of obesity in Malaysia is nothing new. The prevalence of obesity in adults aged more than 18 years old was 17.7%, which was higher than the world obesity prevalence, which was at 13% back in 2016. Apart from the impact that overweight and obesity have in reducing the quality of life, the physical and psychosocial functioning and perceptions of health of people with obesity are greatly affected by this condition. People with obesity experience stigma and discrimination at workplace and at healthcare facilities. Leave alone the patients, doctors even who are obese. I have seen myself when they were counseling patients, they were questioned back asking that, doctor, you yourself are overweight, how can you counsel me? I'm sure some could have listened to this sort of comments before from patients or what. Not only overweight and obesity are associated with chronic diseases like type 2 diabetes, hypertension, dyslipidemia, metabolic syndrome, osteoarthritis, OSA, but it also increases the risk of several types of cancers, as we can see. In women, basically, it's associated with endometrial cancer most of the time, and also breast and ovarian cancers. Right, this is a good picture of us Malaysians, weight-wise. This was by the National Health and Morbidity Survey back in 2019. Survey was based on 15,000 respondents, and as you can see, amongst the overweight and obese, 54.7% were women, and 60% of those were at the age group of 55 to 59. Which the menopausal group, because we can relate that decrease or lack of estrogen along with aging in general triggers metabolic changes. Estrogen, basically, it helps in lipid metabolism. With lack of it, there is an increase of fat deposition, especially abdominal fat. So obesity can be classified based on body mass index. As you can see, this is the formula we use to calculate. But there are two classifications for BMI. One is by WHO and another for the Asian population. So for the WHO, obesity is classified if the BMI is more than 30 onwards, and then they are subdivided into class 1, class 2, and class 3, as you can see here. But for the Asian population, we have a different classification. Why? Because Asians generally have a higher body fat percentage compared to Europeans at the similar BMI cutoff. Evidence from Asian countries reveal that the risk of comorbidities such as type 2 diabetic, hypertension, and other cardiovascular risks start to increase at lower BMI. Hence, the different classifications for Asian. As you can see here, obese class 1 starts from 27.5 rather than 30 from the WHO. So that will definitely increase the obesity population in Malaysia. Now let's look at these bar charts showing the percentages of overweight and obese population in 6 countries in Southeast Asia. And Malaysia sits at number 1 at both categories. And overall, we can see more females than males, as you can see. Both groups, overweight and even obese. So this definitely raises the concern on what is the implication of their health, especially females. So obesity has significant and far-reaching implication on women's life cycle, from early pubertal years to reproductive and postmenopausal years. Okay. Okay, let's start from here. So I know I've been talking about adults mainly, but obesity also does affect children and adolescents. If this matter is not addressed by the parents or guardians, it will continue on to adulthood and cause more problems. Based on this data from WHO, child obesity in Malaysia is second highest in Asia. You can see we're sitting at 12.7%. So the age of menarche is determined by various factors, and one most important is nutrition. As you know, adolescence is a time for enormous physical and psychological changes for a young female. And there appears to be a relationship between the body weight and the onset of menarche, supported by earlier menarche seen in obese girls. Serious gynecological pathologies in this group is rare, but menstrual disturbances are not uncommon and may further disrupt the difficult phase of adolescents and their families. And being obese can affect children's emotional well-being and self-esteem too. And as we know, we hear lots of cases of bullying and whatnot, which they could be subject to that. Okay, now we move along to adults. So we start off with benign gynecological issues. So endometrial polyps, fibroids are commonly seen in obese women, possibly secondary to the effects of excess estrogen. Polycystic ovarian syndrome, obesity does promote the development of phenotype in susceptible females. Due to the obesity, increase in abdominal pressure, they may have stress urinary incontinence, uterovaginal prolapse, and also endometrial hyperplasia, which is a precursor for endometrial cancers if it's not treated. So as such, the obese women may frequently require treatment for these conditions, hence more problems for them. So if the previously mentioned problems need surgical intervention, these are the potential problems they may face. So if they are subject, the risk from surgery, we as surgeons, if we are difficult surgery, the risk of bleeding is higher, and then during the surgery, we have neighboring or surrounding organs injuries. Post-surgery, they can have surgical site infections, wound dehiscence, or even thromboembolism, to name a few. And as for the anesthetic problems, they may have difficulty for cannulation, issues with airway and ventilation, lifting and moving of women, is obese, longer operating hours, possible ICU admissions, needing more analgesia, and also nausea and vomiting. Use fecundity because of the anovulation, polycystic ovarian syndrome, insulin resistance, and majority of women with obesity may continue to ovulate on a regular basis. Therefore, they should view themselves as potential being pregnant. So if you look at this image, so why obese women have issues with fertility? Because obese women have reduced receptivity of endometrium. They may have atresia of early follicles and apoptosis of follicles. increase in inflammatory cytokines interfering with fertilization. They may have insulin resistant, hyperinsulinemia, and reduced sex hormone binding globulins, and also gonadotropin releasing hormones from hypothalamus. All these will lead to infertility. In brief, this can happen to obese females, weight gain, insulin resistant, increased testosterone, and ovulation, hirsutism, fertility. Hyperinsulinemia actually causes overstimulation of ovarian stroma, which there increases androstenediones and also testosterone synthesis, leading to infertility. Lots of issues. So we move along to obstetrics, which is uh, one of the big problems which we are facing. So obstetrics and obesity don't go along quite well. In obesity in pregnancy, quite common, especially in our clinics, we see women who are classified as obese. So they are associated with multiple problems. So we can divide it into maternal problems and also fetal problems. So what are the risks associated with obesity for the mother, for the maternal? So as I mentioned earlier, reduced frequency of fertility issues, further weight gain during pregnancy on top of their current weight, increased risk of gestational diabetes and also hypertension and preeclampsia, vitamin D deficiency, venous thromboembolism. Women who are obese, they may have higher rates of induction of labor, and women, especially with a BMI more than 40% when they are induced, they have 50% failure rate leading cesarean section. Also, they definitely have anesthetic doctors. Our colleagues will have difficulty giving regional anesthesia. And then for us, be a challenge performing cesarean sections due to the thick abdominal wall. And also, this population of patients will have increased risk of postpartum hemorrhage. And as for the fetus, what are the risks? Basically, start off with higher risk of miscarriages. Uh, babies can have neurotype defects or congenital heart diseases. Baby can be large for gestation of age, which can lead to risk of poor progress needing cesarean section, or if they have a vaginal delivery, there can be a risk of shoulder dystocia, the risk of stillbirth, preterm delivery, and as the mother's maternal abdomen, as the mom's abdomen is thick, there could be a challenge for us to perform ultrasound to detect any abnormalities. And postpartum babies can have risk of hypoglycemia, and later on, these children may have early development of metabolic diseases. So these are all the risks which is involved. So how is the best way to limit the potential complication for these mothers? So best is to conceive with a BMI of less than 30. But however, if they have already conceived, so we should advise the mothers. These are the advised maternal weight gain during pregnancy, which is advised. So if you can see mothers with BMI more than 30, we advise them to put on a maximum of 9 kilos. But I'm sure mothers here can relate that there is definitely an increment of more than 9 kilos during pregnancy. And because on average, a woman puts on 10 to 12.5 kilograms during a pregnancy. So lots of issue on top of the risk which they may face during pregnancy. Next, we move on to contraception. So ensuring a woman with raised BMI can safely and effectively use contraception is crucial. So safe and effective pregnancy prevention is critical women with obesity because, as I mentioned earlier, some women who are obese, they will definitely plan to reduce their body weight in order to conceive prior to avoid or reduce the risk further on. So we as doctors play a crucial role in counseling them on what sort of contraception may be suitable for them. The primary safety concerns for women with obesity using contraceptions are cardiovascular risks from the exogenous estrogen, including VTE, acute myocardial infarction, ischemic stroke. But why? This is simply because the estrogen leads to increased thrombin generation and fibrin clots, by the increased level of coagulation proteins and decreased level of anti-coagulation protein. So we have to be very, very careful. So called the UKMET, deciding what is the safest option available. So as you can see here, it is divided to category 1 up to 4. So like category 1, there's no restriction. Category 2, advantage outweighs the risk. And whereas category 3, there are theoretical proven risks which outweighs the advantages. And category 4, basically we should avoid. So for women with who are obese without any coexisting medical condition, so the best would be progestin-only contraceptive, as I mentioned earlier. We should try to avoid estrogen ones. Best would be intrauterine contraception, which is our Mirena intrauterine device. And for the group of women, we should avoid all estrogen containing contraception because they are all categorized as UKMET2 and UKMET3. Means we should reconsider. We should classify them accordingly because patients who are BMI 30 and above or 35 and above, the risk of developing VTE, cardiovascular risk is higher. So that's why they've been categorized as UKMET2 and 3. So for women with BMI, raised BMI with other risk factors, in addition to obesity, such as their smoking, diabetes, hypertension, dyslipidemia, the best would be copper intrauterine device. Because the rest, such as the Mirena, even progesterone-only pills, they're all UKMET2 and 3 because prostagenic components may contribute to the increased risk of stroke and ischemic heart disease also in these women, this particular group of women taking these preparations. So we have to be quite careful. So this is the summarized eligibility criteria. If you can see here, progesterone is mainly safe for obese women without any risk factors. But if they are obese plus any risk factors, the best would be just a copper intrauterine device. Next, we move on to the gynecological cancers. So we all know that obesity has been associated with increased incidence of gynecological cancer and also poor survival of cancer. So this was published under the BBMJ, Obesity, Gynecological and Obstetric Conditions, an umbrella review of the literature. So 258 meta-analyses that analyzed the association between obesity and incidence of 84 different obstetrics and gynecological outcomes. There was strong evidence to support that association between obesity and the following outcomes, which is sitting at number 1 and number 2 are endometrial cancers and ovarian cancers. To name the rest is, as I mentioned previously, fetal macrosomia, preeclampsia, low Apgar, antenatal depression, and also cesarean sections. For endometrial cancer, for example, due to the high amount of circulating estrogens exposure to the endometrial lining, this will favor the overdevelopment of the lining, causing hyperplasia. And if this is not intervened, this will lead on to endometrial cancers. So the question comes next is, so how do we overcome this? How do we overcome obesity? How do we counsel our patients? So the principal goals in obesity management are, number 1, we should prevent complication by trying to keep the patient metabolically healthy. We should prevent or treat the existing comorbidities. We should help them. And at the end of the day, we should restore the individual's well-being, positive body image, and also self-esteem. It's very important for them to proceed with the treatment. So this is the algorithm which I have taken from the CPG or Management of Obesity Guidelines by MOH, which was just second edition, which was just updated this year. So in summary, so like how we normally do, patients come to our clinic, we calculate the BMI, and then we classify them. And then we also we find out what are the risk factors. We also find out if there are any medications. And then depending on what are the risk factors, when we will engage them to some weight loss programs, we can always refer to our colleagues here, the sports medical physician, to put them under some regime physical activities, to go through some program. At the same time, we do also educate the patients on lifestyle modification, refer them to the dietitian, and then we assess the weight and communities periodically, and then see if they need therapies or they need referral to the bariatric surgeons and whatnot. So we always tell patients, lose weight, but it's easier said than done. It's quite difficult. But with discipline and dedications, it can be done. And we as doctors, uh, setting example to them, they will follow. We can also refer them to the dietitian referrals to help them with their diet modifications to cut down the calories. And as I mentioned earlier, for the exercise, we can also have we have an option to refer them to the sports medicine team. Why is this important to lose weight? Because studies have shown that a modest weight loss of 5% to 10% is already associated with improvements in, for example, blood pressure and also cholesterol levels. So this is the table taken from the Scottish guideline. It shows that benefits of losing only 10% of their body weight. For example, if they're 80 kilos, you lose 8 kilos. You advise them to lose 8 kilos. Or, you give them a target, give them a goal. So that I think that is better rather than, telling them just go lose weight, pergi kurangkan berat badan, you have to guide them on how much to lose. And every visit, you monitor their weight. So we will be able to see with 10% of body weight drop, they will be able to see a reduction in blood pressure, cholesterol levels, improvement in diabetic control, reduced risk of OA, and even reduced risk of mortality. 10% reduction is all you need to kickstart in reducing the overall risk of the patient. This is how you consult the patient. So for obesity should be only used as a tip. So for any of patients with or any ones with a BMI of more than 30, we can advise them. But if they have comorbids from 27.5, we can already start them on some pharmacotherapy medications. So the USDA approved medications for obesity, as mentioned, these are the 5 drugs which is mentioned: Orlistat, phenethylamine, and then combination of 2 different drugs, and our Saxenda, which is a liraglutide, and also the Ozempic, semaglutide. These are all approved. But in Malaysia, the anti-obesity drugs available are Orlistat, phenethylamine, liraglutide, and semaglutide. But in UMMC, the ones available are our Orlistat, liraglutide, and our semaglutide. These 3 drugs which is available in UMMC at the moment of time. So usually the Ozempic or semaglutide is used mainly to help in reduction of to help in improving their sugar control, also at the same time reducing body weight. And there's only one head-to-head RCT available comparing orlistat and liraglutide, which results in liraglutide or Saxenda, which has got a greater efficacy in weight loss. So if that doesn't work, then bariatric surgery can be performed in individuals who are morbidly obese and fail medical therapy. So I've mentioned earlier, there are 2 different types of procedures done by the surgeons, which are the restrictive procedures and malabsorptive procedures. But not all can be subjected. So in 2021, the Malaysian Bariatric and Metabolic Working Committee published indications or consensus statements on whom can be subjected to bariatric surgery. So the ones who are morbidly obese without any complications and who fulfill the selection criteria, BMI of 37.5, can be subjected to it. But for those with morbid obesity and metabolic syndrome with a BMI 32.5 plus fulfills the selection criteria, can be subjected to bariatric surgery. So in obstetrics, the National Institute of Health and Care, NICE UK, has recommended that bariatric surgery is an option for morbidly obese patients, BMI more than 40, planning to get pregnant when lifestyle modification and medication have failed. So these are the guidelines for obesity. in obstetrics. Sorry. So in summary, if you look at this, so balanced diet and regular physical activity in all groups, all individuals should be following this regardless of their body size. But for pharmacotherapy, as I mentioned, 27.5 onwards with COVID, you can start. Otherwise, 32.5 and above, you can be subjected. And for surgery, with metabolic syndrome from 32.5, and without metabolic syndrome is from 37.5. So, so this is the clinical practice guidelines, which is the management of obesity, which I have taken most of our information in terms of management, which is released by Ministry of Health. It is it's quite good, and it can easily be obtained online. So I think everybody should read this so that we can offer the best care of management for our patients. So I think this is my last slide today. So thank you very much. Yeah, so I actually just included this slide. It's actually done by my 9-year-old daughter. She was actually tasked by her school teacher to write about obesity. So I think it's a good initiative by the school to start, to create awareness among students at a very early age, is because we can see now obesity in children is on the rise. So yeah, I think it's a good thing by the schools.
Thank you, Ruben, for that great talk, and also very cute that your daughter has put there. So I think with the interest of time, I got a few questions, but I think Prof. YK has put a question here for us. So Prof. YK said that there's most Presbyterian actually arrived in the first antenatal clinic very early, and we have calculated the BMI. And what would be the true reflection of their BMI? And our patron usually tend to arrive late. And would the BMI calculated locally be reflective, especially as patron gain one BMI above their norm by the term? So it means that what kind of BMI do you use for, I mean, managing patient in labor? So you use the booking BMI or the current BMI, or what is your view on that?
So basically, when they come in for booking, we normally definitely will calculate from the booking BMI, because only with the booking BMI, then that's how we can gauge, or we can counsel the patient on how much of weight we could ask a patient can be subjected to put on throughout their pregnancy. But as she goes towards labor, of course, we will take on the patient's latest BMI rather than their booking, because they can put on a lot of weight along the way. They may go on, like, as I said, on average, it's 10 to 12.5, but they can go up to an increment of almost more than 15 kilos to 20 kilos. So towards labor, we would take into consideration of their latest BMI.
Okay. I think if we look at the thromboprophylaxis guideline, we actually look at the booking BMI for starting the
Yep.
thromboprophylaxis.
Yep.
But of course, during labor, we normally do the BMI again during the thing. Okay. So any more questions? There's no more question, but I just want one more question, Ruben, for you to highlight to the audience. Is the weight change improve the fertility? What do you think? So now we know that the obesity is actually prevalent and it can cause infertility. Would weight change improve, reverse it, or how? Just to educate us
So,
here.
so as I mentioned earlier, obese women has got reduced fecundity. So I think I should mention also that a weight loss of 10% of their body weight can increase fertility rate between 77 to 88% to conceive. So we have a lot of patients who are obese, and I'm sure under the fertility care, before they embark on fertility treatment, increases. So yes, to answer the question, reduction in body weight does increase the risk, the success rate of fertility up to about 77% to 88%.
Okay, I think we're already 2 minutes past 9 o'clock, so I think we should close the session. Well done, Ruben, and thank you everyone for coming. And I think the admin has put the link for you to fill in the form for you to get the CPD points. So please fill in the form and till we meet again for the next breakfast at UML. Thank you very much and have a good day.
Thank you very much.